Chapter, we address how epidemiology is used to evaluate the effectiveness of screening programs for the early detection of disease, secondary prevention. This subject is important in both clinical practice and public health, for there is increasing acceptance of a physician's obligation to include prevention along with diagnosis and treatment as major responsibilities in the care of patients. In using a test to distinguish between individuals with normal and abnormal results, it is important to understand how characteristics are distributed in human populations. Figure 1 shows the distribution of tuberculin test results in a population. The size of the induration, diameter of the area of hardness at the site of the injection in millimeters is shown on the horizontal axis and the number of individuals is indicated on the vertical axis. A large group centers on the value of 0 millimeters no induration, and the other group centers near 20 millimeters of induration. This type of distribution, in which there are two peaks, is called a bimodal curve. The bimodal distribution permits the separation of individuals who had no prior experience with tuberculosis, people with no induration, seen on the left, from those who had prior experience with tuberculosis, those with about 20 millimeters of induration, seen on the right, although some individuals fall into the gray zone in the center and may belong to either curve. Most of the population can easily be distinguished using the two curves. Thus, when a characteristic has a bimodal distribution, it is relatively easy to separate most of the population into two groups, for example, ill and not ill, having a certain condition or abnormality and not having that condition or abnormality. In general, however, most human characteristics are not distributed bimodally. Figure 2 shows the distribution of systolic blood pressures in a group of men. In this figure there is no bimodal curve. What we see is a unimodal curve, a single peak. Therefore, if we want to separate those in the group who are hypertensive from those who are not hypertensive, a cutoff level of blood pressure must be set above which people are designated hypertensive and below which they're designated normotensive. No obvious level of blood pressure distinguishes normotensive from hypertensive individuals, although we could choose a cutoff for hypertension based on statistical considerations. We would ideally like to choose a cutoff on the basis of biologic information, that is, we would want to know that a pressure above the chosen cutoff level is associated with increased risk of subsequent disease, such as stroke, myocardial infarction, or subsequent mortality. Unfortunately, for many human characteristics, we do not have such information to serve as a guide in setting this level. In either distribution, unimodal or bimodal, it is relatively easy to distinguish between the extreme values of abnormal and normal. With either type of curve, however, uncertainty remains about cases that fall into the gray zone. The validity of a test is defined as its ability to distinguish between who has a disease and who does not. Validity has two components, sensitivity and specificity. The sensitivity of the test is defined as the ability of the test to identify correctly those who have the disease. The specificity of the test is defined as the ability of the test to identify correctly those who do not have the disease. Suppose we have a hypothetical population of 1,000 people, of whom 100 have a certain disease and 900 do not. A test is available that can yield either positive or negative results. We want to use this test to try to distinguish persons who have the disease from those who do not. The results obtained by applying the test to this population of 1,000 people are shown in Table 1. How good was the test? First, how good was the test in correctly identifying those who had the disease? Table 1 indicates that of the 100 people with the disease, 80 were correctly identified as positive by the test, and a positive identification was missed in 20. Thus, the sensitivity of the test, which is defined as the proportion of diseased people who were correctly identified as positive by the test, is 81/100 or 80%. Second, how good was the test in correctly identifying those who did not have the disease? Looking again at Table 1, of the 900 people who did not have the disease, the test correctly identified 800 as negative. The specificity of the test, which is defined as the proportion of non-diseased people who are correctly identified as negative by the test, is therefore 800/900 or 89%. Table 2 compares the results of a dichotomous test results either positive or negative with the actual disease status. Ideally, we would like all of the tested subjects to fall into the two cells shown in the upper left and lower right on the table. People with the disease who are correctly called positive by the test true positives, and people without the disease who are correctly called negative by the test true negatives. Unfortunately, such is rarely if ever the case. Some people who do not have the disease are erroneously called positive by the test false positives. And some people with the disease are erroneously called negative false negatives. So far we have discussed the test with only two possible results, positive or negative. But we often test for a continuous variable, such as blood pressure or blood glucose level, for which there is no positive or negative result. A decision must therefore be made in establishing a cutoff level above which a test result is considered positive and below which a result is considered negative. Let us consider the diagrams shown in Figure 3. Figure 3a shows a population of 20 diabetics and 20 non-diabetics who are being screened using a blood sugar test whose scale is shown along the vertical axis from high to low. The diabetics are represented by blue circles and the non-diabetics by red circles. We see that although blood sugar levels tend to be higher in diabetics than in non-diabetics, no level clearly separates the two groups. There is some overlap of diabetics and non-diabetics at every blood sugar level. Nevertheless, we must select a cutoff point so that those whose results fall above the cutoff can be called positive and can be called back for further testing, and those whose results fall below that point are called negative and are not called back for further testing. As shown in Figure 3b, suppose a relatively high cutoff level is chosen. Clearly, many of the diabetics will not be identified as positive. On the other hand, most of the non-diabetics will be correctly identified as negative. If these results are distributed on a 2 times 2 table, the sensitivity of the test using this cutoff level will be 25%, 5/20ths, and the specificity will be 90%, 18/20ths. As shown in Figure 3c, what if a low cutoff level is chosen? Very few diabetics would be misdiagnosed. What then is the problem? A large proportion of the non-diabetics are now identified as positive by the test. As seen in the 2 times 2 table, the sensitivity is now 85%, 17/20ths, but the specificity is only 30%, 6/20ths. The difficulty is that in the real world, as shown in Figure 3d, no vertical line separates the diabetics and non-diabetics, and they are, in fact, mixed together, as shown in Figure 3e. In fact, they are not even distinguishable by red or blue, as shown in Figure 3f, if a high cutoff level is used. All those with results below the line will be assured they do not have the disease and will not be followed further, as shown in Figure 3g, if the low cutoff is used. All those with results above the line will be brought back for further testing. Figure 4a shows the distribution of blood sugar levels in hospital patients with diabetes and without diabetes. The number of people with diabetes is shown for each specific blood sugar level in the upper distribution for persons without diabetes. Because of limited space, the number of people for each specific level of blood sugar is not shown in the lower distribution for persons with diabetes. Figure 4b and c show 2 different blood sugar cut points that were used in the study to define diabetes. Data from the graphs are presented to the right of each graph in a 2 times 2 table. B. When a blood sugar cut point of is greater than or equal to 80 milligrams per deciliter is used to define diabetes in this population, sensitivity of the screening test is 100%, but specificity is low. C. When a blood sugar cut point of is greater than or equal to 200 milligrams per deciliter is used to define diabetes in this population, sensitivity of the screening test is low, but specificity is 100%. Figure 4a shows actual data regarding the distribution of blood sugar levels in diabetics and non-diabetics. Suppose we were to screen this population. If we decide to set the cutoff level so that we identify all of the diabetics 100% sensitivity, then as shown in Figure 4b, we could set the level at 80 milligrams per deciliter. The problem is, however, but in so doing we will also call many of the non-diabetics positive, that is, the specificity will be very low. On the other hand, as shown in figure 4c, if we set the level at 200 milligrams per deciliter so that we call all the non-diabetics negative 100% specificity, we now miss many of the true diabetics because the sensitivity will be very low. Thus, there is a trade-off between sensitivity and specificity. If we increase the sensitivity by lowering the cutoff level, we decrease the specificity. If we increase the specificity by raising the cutoff level, we decrease the sensitivity. To quote an unknown sage, there is no such thing as a free lunch. The dilemma involved in deciding whether to set a high cutoff or a low cutoff rests in the problem of the false positives and the false negatives that result from the testing. It is important to remember that in screening we end up with groups classified only on the basis of the results of their screening tests, either positive or negative. We have no information regarding their true disease status, which, of course, is the reason for carrying out the screening. In effect, the results of the screening test yield not 4 groups, as seen in figure 5, but rather 2 groups, one group of people who tested positive and one group who tested negative, as seen in figure 6. Those who tested positive will be notified of their test result and will be asked to return for additional examinations. The other group, who tested negative, will be notified that their test result was negative and will therefore not be asked to return for further testing. The choice of a high or a low cutoff level for screening therefore depends on the importance we attach to false positives and false negatives. False positives are associated with costs, emotional and financial, as well as with the difficulty of belabeling a person who tests positive and is later found not to have the disease. In addition, false positive results pose a major burden to the healthcare system in that a large group of people need to be brought back for a retest when only a few of them may have the disease. Those with false negative results, on the other hand, will be told they do not have the disease and will not be followed, so serious disease might possibly be missed at an early treatable stage. Thus, the choice of cutoff level relates to the relative importance of false positivity and false negativity for the disease in question.